Onc Live Insights is a video editorial program produced by Onc Live.
Patients who have received first-line therapy will ultimately all relapse, and so treatment resistance will emerge. It's difficult when exactly to stop the previous treatment and continue with the second-line treatment. Within the frame of clinical trials, it's very clear, PFS, and then you just wait a washout period and resume with second-line. I think in daily practice you will probably look at how the patient is doing, whether the total amount of tumor burden had really regrowth or whether are really new metastases. So you will weigh sites of metastasis, the aggressiveness of the biology of the tumor, and then decide based on that on an individual patient basis when to start treatment. So I think that will be quite variable in daily practice. I think if it's rapidly progressive, you will certainly need to start in order not to lose a momentum to treat patients in second line. Yeah, because also the second line trials have clearly demonstrated at this moment that there is a benefit to treat patients in second line. But still, a number of patients will be after first line not be fit enough when they progress. The disease will be so bad that they are not able to receive second-line treatment. That's a minority at the moment. Up till very recently, the goal of second-line treatment was probably, of course, prolongation of life, but more so the quality of life of a patient that did not have that much time to live. With the emergence of the data from newer trials, I do think that it's going to change. If you look at the data of second-line treatment randomized trials, the overall survival is so good that I do think that the aim should also in second line be overall survival benefit. So I think that probably because there are a number of trials that were so incredibly positive, that we will probably be much more aggressive in trying to keep patients on treatment and switching to second-line treatments that have shown efficacy and overall survival benefit. The choice of which treatment, which agent in second line is quite difficult because there are many trials at the moment and it's really difficult with even more data upcoming to decide what the best sequence is. I think that RCC had clearly shown that there was an advantage to use an mTOR inhibitor, and it made sense because we as clinicians tend to think that changing classes of drugs is an important thing to do if resistance to treatment emerges. Now that we have more data of TKI sequencing, the AXIS trial testing axitinib and sorafenib in second line, there are switch trial data testing sorafenib and sunitinib, the order of two more or less identical TKIs. So there are more and more trials showing that TKI can still also be very effective. So it becomes more difficult. I think we had pazopanib and sorafenib formally tested in cytokine pretreated patients. We had axitinib, so we had axitinib, pazopanib, sorafenib, and we had everolimus. So we had the mTOR class inhibition and we had the TKI types of sequencing. And choosing between either of the classes is, in my view, if you look at the data, it's not so strong in terms of you have to use a TKI in second line or you first have to use a mTOR inhibitor in second line. mTOR inhibition is also perfectly able to still give remissions in third and fourth line. We know that from RCC because lots of patients had more than 1 or 2 lines of treatment. So everolimus may shift to third line treatment, whereas newer TKIs or checkpoint inhibitors may be replacing our usual second line drugs. But it's quite difficult at this moment to really choose between one or the other. We have a checkmate study We have cabozantinib in second line, which was very powerful compared to everolimus, although the OS data are not mature yet. And we have lenvatinib in combination of everolimus giving extremely good results. So I do think that the landscape is going to change very quickly for second-line treatment.
When we go to second-line therapy in kidney cancer, we have really two different settings. The first setting is we have a bulky disease with symptoms, and then what we want to do is shrink the tumor to improve the symptoms. And the rest of the patients, some are still relatively asymptomatic at that stage, and then we have to favor the quality of life and the survival time. So this is what drives my choice between the two drugs which are the most commonly used in second line, which are axitinib and everolimus. So in a bulky disease with symptoms, I usually prefer to use axitinib because it shrinks more the tumor. In the patients with relatively indolent disease, even in second line, with asymptomatic, I would probably prefer everolimus because it's safer, better toxicity profile, and we still be able to use axitinib in third line. So that's how I choose my second line. I don't care about the response in first line. I mainly care about the tumor burden at the time I start second line. So another very important point when you consider the second line choice is, of course, tumor burden, but also comorbidities of the patients. As an example, if you are going to treat a diabetic patient, you probably will not prefer to use everolimus, where you can have some increase in hyperglycemia with everolimus. If you treat a cardiac patient, you are not going to prefer axitinib, where the risk is going to be more important. So, I mean, beyond tumor burden and aggressiveness of the disease, probably comorbidities are also going to be important in terms of choice of second line and further line.